If someone is postmenopausal, coming with bleeding can come in mainly two different ways. Someone known to have already menopause and she last period maybe a few years ago, now she is coming with new onset UV bleeding. So definitely it's suspected cancer. Any postmenopausal bleeding is suspected cancer until proven otherwise. Okay. Then so you need to rule out all the cancer red flags. Or maybe someone started HRT and then she's coming with bleeding. She's coming with bleeding. And we have discussed this before, and we have updated our materials about this before. So this is not a new in the material. We have this updated before. We'll come, guys. We will come later on today to only something simple. However, because the Faculty of Sexual and Reproductive Health has updated their information, so we have added this in the notes, and we have deleted the old sentence from our materials. So we changed our materials to the new Faculty of Reproductive and Sexual Health guidelines. So we'll come to this when it comes to the contraception. All right, so if someone coming, guys, with bleeding while on HRT, you will approach it the same way. What is the bleeding? How long? Is it one time only or more than one time? Heavy or no? What is the color? Anemia symptoms. Rule out some cancer symptoms as well. Ask about if she's up to date with her smears or not. Very important. Ask about topical symptoms as well. Could be atrophic vaginitis, maybe. So we need to ask about topical symptoms. It's very important. Ask about if she is taking any hormonal tablet or any topical estrogen. You can ask about any lumps or bumps in your hair. Definitely is very important. Also ask about night sweats, weight loss, all of this. Okay. You also can ask about, did you have any abnormal smears in the past? Any history of polycystic ovary? Have you noticed any leg swelling? Or have you noticed any pain in your stomach down below, pelvic pain? Just to make sure there's no any, again, could be some features of suggestive malignancy. Definitely ask when was the last period. It's very important. And is she sexually active or no? Also ask about STI symptoms. Even bleeding, yeah, bleeding can be one of the features of STI infection. Okay, so all of this, those are just the main part that you need to ask about, main parts that you need to ask about. So how you can approach? It is quite common to experience some irregular bleeding during the first 6 months of HRT because your body adjusts to the hormonal changes. This type of bleeding is usually harmless and tends to settle down as your womb lining stabilizes. However, we will arrange an ultrasound to make sure that there is no any other cause and to provide reassurance. When we should do ultrasound scan, we'll come to this. If the patient follows the indication for ultrasound scan, or if the patient came after 6 months from starting HRT, or after adjusting the treatment, and patient is still having bleeding, we need to do ultrasound scan. So if she came after 6 months from starting HRT, or after 6 months from adjusting our dose for the treatment, and she came with bleeding, so we need to arrange a scan to make sure there is no pathology. All right. And please let us know if the bleeding in the meantime, if your bleeding becomes heavier or continue to bleed after 6 months. So management, addressing her eyes, it might be taking by the news station if you are suspecting cancer, face-to-face examination. Except not you will examine your legs, will examine your abdomen, and also I need to examine you from down below to see if you got any lesions in your vagina or cervix, which is the neck of the womb. With a chaperone, I need to examine you. Then either adjust the HRT dose or arrange ultrasound scan. It depends. Give her some leaflet, safety net, and follow-up. So if you suspect cancer, definitely breaking bad news. If HRT related, we will come to the options. Don't forget face-to-face examination. Don't forget blood test as well. Blood test, full blood count, protein is clean, maybe LFTs and UNEs. Urgent scan. In the meantime, if you are referring the patient for suspected cancer pathway, you can also arrange ultrasound scan as urgent in the meantime. Leaflet from patient info, safety net if bleeding getting worse, severe pain, feels unwell, come back please, and follow up after the blood test and ultrasound to discuss the result. So this table is very important. Unscheduled bleeding on HRT. Someone started HRT. She didn't have any undiagnosed vaginal bleeding before, because we mentioned if someone has vaginal bleeding, we should investigate. We should rule out any pathology for starting HRT. Someone clear history, started on HRT, coming with bleeding. What we need to do? So the guideline says now assess the cancer risk factors and the bleeding pattern, if she's at risk of having cancer or not. Then we need to ask about for how long is she taking HRT. If she is compliant with the HRT or not. Does she take the tablet if she's on tablet every day or not? Does she change the patch? Does she change her patch twice weekly on time or not? We need to offer her examination, as we mentioned. Face-to-face is very important, and then investigations if indicated. Maybe cervical screening if she missed cervical screening before, or genital swab if you are suspecting STI, and plus the basic investigations for blood count, Clotting screen, LFTs, all of this. If your patient has one major risk factor or 3 minor risk factors for having endometrial cancer, if she is having 1 major or 3 minors, yes, we need to refer her for urgent ultrasound scan. Urgent ultrasound scan. If the ultrasound scan came back with a cutoff point of more than 7, if she's on sequential HRT or continuous combined HRT, the endometrial thickness more than 4, if yes, she needs to go into a referral pathway for suspected endometrial cancer. If the ultrasound scan after she had the urgent ultrasound scan and the cutoff point came back less than 7, if she was on sequential, or less than 4 if she was on continuous combined, if it is less than this, so we need to optimize the HRT. Maybe HRT needs to be optimized. What does that mean? Either we increase the progesterone or we reduce the estrogen dose. Very important. If there is no risk factors for endometrial cancer, if there is no risk factor for example, she doesn't have 1 major or 3 minor risk factor, if she doesn't have, is the bleeding is heavy and continuous, if she's having 2 minor cancer risk factors, or more than 6 months since we started HRT, or more than 3 months after we changed the dose of the HRT. If yes, she's having any of this, we need to do urgent ultrasound scan. We need to do urgent ultrasound scan. If the urgent ultrasound scan again come back with any of this, okay, about the cutoff point, she needs to go into referral. So if it is heavy or persistent, more than 6 months from starting, more than 3 months from adjusting the dose of HRT, what we need to do? Urgent ultrasound scan. So when we gave our first lecture, maybe more than a year ago, we said, guys, in the first 6 months of HRT, your patient is expected to have bleeding. However, no, now the guidelines has changed. If someone came with bleeding while HRT, even if you started HRT 1, 2 months ago, 3 months ago, we need to follow this flow chart, not to miss anything. Right. So coming back to this arm, so if the bleeding is not heavy, not persistent, maybe spotting once or twice, few times, she doesn't have 2 minor risk factors, maybe 1 minor risk factor or no risk factor, no minor risk factor at all. She's still within the first 6 months of starting the HRT. Or she's still within the first 3 months from changing the dose of HRT. If yes, we need to optimize the HRT for 6 months. What does that mean? Either increase the progesterone dose, not only this, sometimes you can give 2 progesterone, or we can reduce the estrogen dose. And then we see if that will help. Very important. What are the major and minor risk factors? I will let you guys read them. For example, BMI is more than 40 or more. Obesity is a risk factor. Obesity is a risk factor for many gynecological cancer. Ovarian cancer, endometrial cancer, many things. Okay. For example, estrogen only HRT for more than 6 months in a woman with a uterus. If she's taking estrogen only HRT and she's only having a uterus, okay, it is a major risk factor. Tricycling HRT. Can you imagine? As we mentioned, tricycling HRT for more than 12 months. That's why I told you it's better to give the cyclical monthly HRT, because the tricyclic HRT might be a risk factor for endometrial cancer. Why? If you apply the same concept from the polycystic ovary, our aim is to induce bleeding more than 1 time every 3 months, the withdrawal bleeding, to allow endometrial shedding, to build up endometrial cells and epithelial cells in the endometrium, that maybe increase the risk of having endometrial cancer. So tricyclic HRT for more than a year is actually a major risk factor. That's why I told you better if you are giving cyclical sequential or sequential cyclical HRT, try to give the monthly cyclical HRT to induce the bleeding every month, and so on. Actually, here is very good. I don't think, guys, this diagram is complex. It's very simple diagram. For minor, for example, if BMI between 30 to 39, can you imagine diabetes is a minor risk factor? So if for example, she's having diabetes, she's having BMI of 34, she has 2 minor risk factors, and we started HRT probably, let's say, 1 or 2 months ago. What we need to do? Well, according to the flowchart, she's having 2 minor risk factors coming with bleeding, while on HRT, we need to send the head for urgent ultrasound scan. If urgent ultrasound scan coming back positive, to be referred. I hope, guys, that make it very easy, very simple for you. Okay. Also, tricyclic HRT, for example, for more than 6 but less than 1 year, is also a minor risk factor. It's also a minor risk factor. I hope it is very clear. Okay. You can read other minor and major risk factors, but this diagram is very good. It is from British Menopause Society. British Menopause Society. What is the difference between sequential and combined? We already explained. Sequential HRT and continuous combined with HRT. Sequential HRT, again, estrogen. She takes estrogen every day, and with cyclical progesterone, either every month or every 3 months. Better to have it every month. Better to have it every month. Okay? Because that will reduce the risk of having endometrial hyperplasia. The cutoff point on ultrasound, if she's on sequential HRT, the cutoff point is more than 7 millimeters. If it is more than 7 millimeters, she needs to be referred as urgent. Continuous combined HRT, estrogen and progesterone, taken daily without break. So every day, estrogen and progesterone. Not taking progesterone only for a few days or a couple of weeks in a month. She will take every day progesterone and estrogen. The cutoff point is more than 4 millimeters. If more than this, again, urgent to referral to rule out endometrial hyperplasia or endometrial cancer. All right. Bleeding on HRT, either due to too much estrogen. That's why when they say here, guys, optimize HRT, optimize HRT, that means you need to change or play with the dose of the hormones. Either give a lower dose of estrogen or increase the progesterone. Sometimes if we increase the dose of progesterone, they're still having bleeding, and when there is no any pathology, we can give even sometimes 2 progesterone tablets. If no pathology found, no cancer, could be some malabsorption. You need to keep your mind open, could be malabsorption. That's why the oral route is maybe not very effective because hormones are not absorbed that much. Maybe you can change to transdermal and see if that will help. Check compliance. Does she take the tablet every day or not? Could it be because of high estrogen, so we reduce estrogen? Or could be because she needs more progesterone, so we increase the progesterone dose, or it change to different progesterone. Okay, or sometimes even you can give her high dose. All right,